So thank you two for being here. Dr. Taylor is actually a somatic therapist. She practices in New Orleans and employs methods that draw from humanistic, Jungian, transpersonal, and Eastern traditions, using meditation, mindfulness exercises, yoga-inspired movement, breathwork, and talk therapy. She helps clients bridge the mind-body dichotomy. Her interests include yoga, meditation, and the transformative potential of expanded states of consciousness. They inform her style and practice. She's currently working with MAPS, the Multidisciplinary Association of Psychedelic Studies, in the phase 3 study using MDMA-assisted therapy for PTSD. Dr. Taylor holds a PhD in psychology from Northcentral University, a Master's of Science in Nursing from the University of South Alabama, and a postmaster's certificate in nursing from the University of Wisconsin-Madison, specializing in the field of child-adolescent psychiatry. Wow, what a resume for us to dive into today. We're so excited. Dr. Taylor, welcome. Thank you.
Thanks for having me.
All right.
I'll let Dr. Worthy introduce himself.
Yeah, and then I'll just jump into the slides.
Well, I think that we're going to do just kind of take some breaths.
That's right.
Center.
Yeah, my name is Ray Worthy. I'm, I guess, the principal investigator at in New Orleans site for this phase 3 study, and studied psychology at California Institute of Integral Studies, and then had a very badly misplaced midlife crisis going to med school in my 40s at Tulane, and then did a residency in psychiatry at Medical University of South Carolina, where I met and knew of the Midhoffers, and of course wanted to get involved with the MAP study that was taking place there in Charleston, South Carolina. Hello.
Well, I thought we could start with just taking some breaths together and kind of becoming centered. So if everybody can close their eyes and just tuning into your breathing, fully coming into this moment, into your body. And as we breathe together, we can connect with each other and all hold this space together, this space of learning and exploration. Just letting go for the next hour of anything else that's happening. And becoming fully present in this moment together. Taking one more deep breath. And slowly opening your eyes. Thank you. I think that helps us just as much as anyone for sure. I'm going to share my screen now. And here's the little forward arrow. Ray's going to begin. This is our team on the study.
So just click it here to make it go. Yeah, and right, there's, and of course Mesa, who has joined the team since then, and we've been together since about 2016, going back to phase 2 studies, and we're in phase 3 now. Yeah, so today, I guess the main learning objectives are to be able to define PTSD, which is not always easy. understand the mechanisms by which MDMA-assisted therapy may treat PTSD effectively, and be able to describe what inner-directed therapy, looks like. So we are, full disclosure, we get paid for services rendered. I guess we're subcontracted by MAPS to provide the therapy and some of the other things that we do as part of the research. So, MDMA, just a quick history lesson, don't want to belabor it too much. First synthesized in 1912, and it was patented by Merck, and so it's long since off patent. And whatever plans they were hatching for back in 1912 never came to fruition, and it was, forgotten for decades, until Sasha Shulgin, and there's a story where he was working for a pharmaceutical company, and he was so far advanced in his career that they sort of gave him carte blanche to try different compounds, which he did, and he thought this one was pretty incredible. And so it was, let's see here, it was in the 70s. It was in the 70s that it was starting to be used by psychotherapists in the Bay Area, and about 4,000 doses or sessions, psychotherapeutic sessions, took place in the Bay Area. And some like preliminary papers that never really got published in academia were starting to float around. But what was also happening was there was kind of the rave party scene taking off, and people were using MDMA, not in this very conscious set and setting, but really more for partying. And I think that's what got it on the radar screen of the DEA and the FDA. And finally, there was a movement, I guess, within the DEA to have it put on schedule. Sort of the last remnant of probably the war on drugs, starting with the Nixon administration, and to have it put on Schedule 1. But when they started to really look at the various witnesses who came to testify on behalf of the medicine, the DEA administrative judge at the time, Francis Young, he actually ruled that MDMA should be placed on Schedule 3, which would put it on par basically with benzodiazepines. But what was pretty unusual is that he was overruled. The DEA overruled him, which is rare, and put it on Schedule 1, where it remains to this day. So that's where Rick Doblin, who was part of the people, really trying to prevent it from being scheduled on Schedule 1, he founded the Multidisciplinary Association for Psychedelic Studies, also known as MAPS, in 1986, and he's been pretty relentless ever since then, trying to advocate that this medicine could be helpful to society in many different ways, and to get it off Schedule 1. Yeah, and for where we're at right now, just I think a lot of the phase 1 studies really were already in place, different safety measures and mechanism of action. Phase 2 studies, when you're trying to bring a medicine to market, are usually proof of concept. Does it seem to work? What would be a way to operationalize a larger phase 3 study to have a placebo-controlled, randomized, double-blind study to then present the results to the FDA and have the medicine taken off Schedule 1. And that's where we're at now. After successful phase 2 results that were pretty unprecedented, we're now in phase 3, where and there's been a lot of publicity, not in the popular press as well as in peer-reviewed journals. The most recent, kind of wish we had the phase 3 results were published in Nature Medicine. I guess that was last month. So that was that's a well-respected journal, and the results were remarkably successful considering, the chronicity of PTSD. So we're at the place where we're trying to start up and get through the second phase 3 study, and then hopefully in 2022, early 23, be finalizing a new drug application and basically trying to get the medicine off Schedule 1. So when we talk about, and just pop in with questions if anyone has any thoughts. We're talking about PTSD. Of course, everyone can look into DSM-5 and come up with the symptoms, but the definition, and I'm curious if anyone else has other ways of conceptualizing it, but basically something jarring happens in the human being's life, and it's going to be life-threatening generally, or vicariously so. And it's as if the three aspects of the human brain, the sort of more primal reptilian regulatory brain, the limbic emotional brain, and then sort of the frontal lobes, the cortex, the mammalian parts of the brain, they get a little they're not as congruent, and messages are coming in through reptilian brain type conditioning, where things trigger people to have increased heart rate or kind of a fight or flight response that seems inappropriate, but because of the associations they're having, they start to have a lot of associations, nightmares, avoidance symptoms, getting triggered into kind of an autonomic storm, or kind of numbing out. It's kind of phasic between overactivation and numbing or dissociation. And it's all in relationship to an unprocessed traumatic event that sort of becomes more intrusive and leads to lifestyle changes and can be disabling. And there hasn't been too many good treatments. I think Zoloft and Paxil are SSRIs that have been used, but with pretty modest effect size. And don't know that there's been any studies coupling those SSRIs with psychotherapy. But what we're trying to do is, really this gold standard is this where it brings the, yeah, psychotherapy is going to be the definitive treatment. But people get overstimulated, like they become overwhelmed, or might dissociate. It just, so like exposure therapy can be overwhelming for people. And the thought process with MDMA is, how could it serve as a catalyst? And I guess part of what it does is, if someone is telling their story from a traumatic event, they're just getting overwhelmed, their heart rate's increasing, autonomic system is really in overdrive. It makes it hard for them to think on their feet and effectively process or feel safe enough to process. And that's the big handicap psychotherapy is facing. And what some of the things that MDMA can bring about: increased feelings of empathy or interpersonal connectedness, as well as connectedness to oneself, sort of a deeper acceptance of what one's life story is, and realizing it's okay, and decreasing of fear and defensiveness. What's unique about MDMA is, in psychotherapy, it creates a quicker sort of bond between therapists and subject. Stuff that can take months or even well over a year can happen relatively quicker with MDMA. And this sort of heightened state of consciousness is what allows this connection to self and insight into the events that were traumatizing to be processed in a different way. We're basically, usually when we're traumatized, if I walk into a room and I see snakes in the corner, I stop, I'm scared, my heart rate goes up, my breathing is shallow. It's a fight or flight, it's an adrenaline situation. or what is referred to as a polyvagal activation. But if I turn on the light and I see it's just coiled rope, then my frontal lobes, which had been overwhelmed by my reptilian and limbic brain, they reassert themselves. Oh, it's just rope. We can call off the alarm. And my, primal reptilian brain and my limbic brain will actually listen. But short of that type of simple situation where you turn on the light switch and you realize it's just ropes, we have a harder time regulating our reptilian or autonomic overstimulation that occurs with flashback symptoms, et cetera, PTSD. We have a harder time doing that with our thoughts. And that's the frustration of it, where people feel like their body is betraying them. And the reason MDMA is showing some promise is the part of the brain that gets activated when I walk into the room and see the snakes is the limbic aspect of the brain called the amygdala, and it's just basically a part that's looking for pattern recognition. And when there's a break in pattern, there's stop, and there's a sense of danger. It's all about surviving basically and passing the DNA along. And the amygdala is sort of like the watch in the watchtower looking out for that stuff. But if we turn on the lights and see that it's just ropes, then the frontal lobes, which literally get deactivated in trauma recall, they go offline while the amygdala is activated. That switches. And again, it's simple when it's just a rope and you turn on the light, but in real life, it's very hard for us to talk ourselves out of that sense of impending doom, danger, and fear. And that's what's unique about MDMA, is that it can actually accomplish that. And we're going to show a video clip and might speak to that briefly as to, it's kind of a demonstration of how the MDMA comes into play. And just for FYI, there's an increase in serotonin, dopamine, norepinephrine. But I think what's most fascinating about MDMA is the kind of the neurohormonal cascade of events, where there's an increase in oxytocin, prolactin, vasopressin, cortisol. But really, it's the oxytocin, right? There's this sort of sense of attachment and bonding that can occur with oxytocin. So I often wonder if that's like the secret to the sort of catalyst aspect of MDMA and psychotherapy. And is that pretty much, is this where you're going to take over? I'm going to defer now.
So just to talk a little bit about how we've been using this medicine with psychotherapy. The protocol for the study that we've been working on together is it's about a 5 to 6 month process for the patients to go through, and it starts with medical screening. So it's quite involved, just making sure that they don't have any health issues that could then, look like it was possibly due to MDMA. So people have to be relatively healthy for the most part. And then there's a psychological screening that's done by independent raters, which are psychologists that are, they don't know where in the study the person is. They don't know if they've had, one MDMA session or not. And so it's a very kind of unbiased view, and they give them the mini, which is just to rule out any comorbid conditions, the SKID, which looks at personality disorders, and then the CAPS, the clinician administered PTSD scale, is sort of the gold standard for diagnosing PTSD, and that's the measure that we use to, it's given before, during, and after these sessions to see how the patients have improved with their PTSD symptoms. And this slide just kind of goes into some of the aspects that some of the reasons that MDMA seems to be effective. One of the things that I think is kind of interesting is that it can allow for memory reconsolidation. And so when someone has a traumatic event, sometimes memories are just not properly consolidated. And an example of this, one of the patients that Ray and I worked with, um, she had, during her MDMA experience, she remembered this situation during her traumatic event where there was dogs kind of, running around on this wood floor, and she had completely forgotten about that. But in her everyday life, every time she would come home and go to unlock her door and hear her dogs kind of coming to the door, she would have this physical response. And she'd kind of go into this fight or flight, and she never really understood why this was happening, because she loved her dogs and had no issues with them, but she just noticed that this would happen every time she came home. And during her MDMA session, she remembered that there were dogs, running around during this traumatic experience, and she was able to sort of make the association, and that really just changed everything for her, just really having the understanding of where that was coming from. There are about 16 sites for this study around the world. Actually, there's also now a site in Israel, and I think somewhere else in Europe. Yeah. So it just kind of gives you a little overview of where all of the sites are. And just to go into how the structure of the study is. So we give MDMA 3 times, and that's the experimental session that you see here. So half of the participants get placebo and half get MDMA. So after the screening process, we do 3 preparatory sessions where we really talk about, what is the intention of going into this. We get to know the participant and just build rapport. It's, really important that they can, feel like they trust us, because we're, really asking them to take this substance. And, many of them have never, taken anything like this before. So that can be, pretty scary. And so we just, try to prepare them for this. All of the sessions with the participant are done together with a male and a female therapist. So we give the MDMA, they come in the morning, we give them the MDMA or the placebo, and then we stay with them for 8 hours while they, are kind of processing things. We encourage them to go inside, we call it. This is sort of part of the inner-directed therapy, which I think we'll get into in just a minute. And that involves putting headphones on and eye shades and lying down, and really just kind of paying attention to what's happening in their body, and kind of what's coming up for them. So we do this process 3 times over this 5 to 6 month period, and each MDMA or placebo session, they're a month apart from each other, and then we have integrative sessions in between. And in these integrative sessions, we essentially talk about how to integrate the insights or some of the experiences that they've had in the experimental session into their everyday life, and just sort of process, what happened, and then also prepare for the next session. So just to talk a little bit more about inner-directed therapy, originally it was called self-directed, but they've sort of changed it to inner-directed. But it really just means that we basically have this kind of belief that our bodies can move towards healing, just like if you get a cut on your leg or something. If given the right environment, our bodies will heal. And the psyche will do the same if given the opportunity. And often in traditional psychotherapy, you're seeing someone maybe for 50 or 60 minutes once a week, and it's really tough to get go deep in that amount of time. And so I think that, a big part of why this is so effective too is that you have a full 8 hours here to really dive in, and just giving people the time to allow their own process to unfold. Is really powerful. And we're the therapists are more than anything just kind of holding space, mirroring their experience. It's it's really the person that is having their own insights. And that's one of the things that really drew me to this work is, and you'll see it in the video that we show, is that people really come to their own healing, because healing looks different for everyone, and we don't know what that looks like for everyone, but their own inner healer does. And so it's really powerful to be able to watch people kind of sink into their own truth and kind of come up with what they specifically need to heal. And we try to set the office up just kind of like a cozy living room. This is a picture of one of the offices, and we make the couch into a bed with so that they can lie down and be comfortable. um, and then did you want to kind of just preface this video with what
Okay.
a few things?
Um, sorry to interrupt, Ray and Sherry. Just a really quick question.
Sure.
One from the chat and one of my own questions. The first one is, why is screening for HIV needed to participate?
Well, I think that pretty much most of the screening that we do, because it's we're trying to bring this, it's kind of like bringing a new drug to through the FDA process. So if someone is HIV positive and they have something come up just because their immune system is suppressed, then every single thing that comes up in the study, whether it seems to be related to the study or not, even if someone just trips and falls and breaks their ankle, that is then an adverse event. And so any kind of adverse event has to be reported, and then it's forever tied to MDMA, even though it probably didn't
Right.
have anything to do with the MDMA. So
Yeah, it's like, and similarly for like hypertension, Hep C positive status. So they're not, excluded because of those conditions. But yeah, this is like for post-marketing, issues around, yeah, is the medicine appropriate, for different demographics, including, certain diagnoses.
Okay.
yeah, so if it does get moved from a Schedule 1, um, that would not be a reason for someone not to be able to get this type of therapy. It's just for the research.
Ah, okay. And then my question was, when you have two therapists, what is the indication for having one male and one female?
Astute question, because cutting edge stuff, right? Where they're actually, it's, I know there's going to be, or perhaps there already have been, all female teams, and I'm not sure if there's, a movement for all male teams. But this goes back to Stan Grof and his work. He's a transpersonal psychiatrist. He was one of the early LSD researchers out of Czechoslovakia, but he's been in the United States for over 50 years. And that was just his model, but I think it's, it's a fluid model. And so there's going to be changes. And I think obviously when it comes to, even gender related issues, there's going to be more and more flexibility, that this needs to be an inclusive model.
And I think it provides the opportunity to just have sort of both the masculine and feminine energies there. And it makes the availability for transference to, say one of the patients that we worked with, she'd been raped, and she had, just obviously a lot of strong feelings towards men, and she was able to sort of act some of that out towards Ray, and you know, have it sort of land in a way that was different than, you know, what she maybe had expected. And I think it was, you know, really useful for her.
Right, and in an intentional environment with a, you know, a safe therapeutic container, there's certain things that we can maximize. But again, it's like ultimately the healing, right, is within, you know, how it's going to look is, you know, within the subject themselves, and that's why I think we're starting to get more fluid with this model. But I agree with what Sherry's saying as well. So we just tailor it to the people's needs, and hopefully enough therapists will be trained so that, you know, whether it's people of color and different ethnicities, you know, we want each individual to, you know, feel very comfortable in the room with the co-therapy team, and however that team needs to look.
So do you want to
Oh yeah.
introduce the video?
So yeah, Nick, I was an adherence rater when I was in psychiatry residency. So I'd look at, you know, hours upon hours, probably hundreds of hours of MDMA session tape. And I actually was lucky enough to see all 6 of his sessions. The study design was a little different. He had 6 sessions. I got to sit in on the last session, which was really special because you know, I'd studied the guy from top to bottom with all the session tape. And this particular, you know, compilation includes material from different sessions, but just I'll just say a couple things and then we can run it. There's a way, one of the psychological theories we use is called internal family systems. It's basically normal multiplicity. We all have different parts within us and we're not pathologizing. It's just, I got different parts in me. I'm a scared little 4-year-old boy. I'm a, you know, a semi-poised adult and everything in between. These different parts to our personality. Um, and then and different parts sort of get their hands on the wheel and try to run the show, and you know, can turn out well and it can turn out badly. But in this particular theory, there's a sense of really a deeper self. If you know, these parts are a 3-ring circus, you need someone to kind of, you know, run the show, and that would be, you know, self with more of a capital S that can kind of orchestrate it all, and that's rarely present in us. And conditioning, social conditioning, trauma tends to suppress, and we just want to fit in and things like that or get by. But our true, you know, all these parts are great, but they sort of need to be managed. And there's an aspect within us that's pretty deeper and wise that can do that. And you sort of see it come up in Nick early on, where, you know, when he was first getting activated, it looked like there's going to be a panic attack that normally we can't really talk ourselves down from with our frontal lobes to the reptilian brain. You know, all those autonomic symptoms are happening. But for the first time, he was able to attenuate it, and it kind of, you know, surprised him. And it was his first MDMA session. And so that's when, you know, I think he knew he was in for something special, because this medicine was a game changer. Um, and the next part of the tape, it's sort of he's telling his story, and it's he, you know, he has more grounded somatic affect in the telling of his story. It's just not like a loop, like maybe he's told his story hundreds of times, but on MDMA as a catalyst, the processing is different. And that's something we see when he's telling the story on parts of this video, as well as a sense of forgiveness for himself and some of the things he may have done, whether it was in combat or when he was home, and much more volatile after, you know, having PTSD. And there's some catharsis training, a lot of emotional things going on. And then at the very end, sort of his making peace with it all when he's listening to some music, some Middle Eastern music that was more soothing and healing, and he was okay with everything that had transpired. So just by way of introduction, I thought I would say that. Y'all have any questions before we start this?
Can I ask a quick question?
Please.
So you're talking about like listening to Middle Eastern music. I'm assuming that might have been a trigger for him beforehand. And so I'm wondering, even if this is self-directed therapy, is, as the therapists, you know, have discussed with the client ahead of time what their goals are, if they ever introduce potential triggers into the therapy session in order to assimilate them.
It was Nick's idea, and I suspect he must have brought that music in because it was something he heard on a regular basis. I'm thinking this was in Iraq, and I would say normally that's not going to see the therapist set things up like that, because it really is going to be more. It's going to be directed by the participant, the subject, and so this was his thing, and I guess he was at a place where he because there were aspects of it that he found beautiful, and I think there'll even be a little quote in it, because for him it was more about, you know, I guess the shared love of humanity that he could finally reconnect with. All right, here we go. I think it'll last about 9 minutes.
Are you ready to take your counsel?
Sure. And that's Michael and Annie Midhofer.
I just wanted to tell you, I had this this really intense feeling come over my body, and my heartbeat started beating real fast. But I didn't get at first. I started feeling a little afraid, but then once I started breathing, I've never felt that before. I literally felt my heartbeat start to slow down and everything when I started breathing and just relax, and the sensation. And it was amazing how not quickly it went away, but just how in control I felt of making it go away. So usually I've had those feelings. In a way, it kind of felt like when a panic attack kind of comes on, and my heartbeat started, and I felt my whole body flush and get really hot. And then I was just amazed how I was able to not really fight it, but kind of relax. Yeah,
So you
thanks. Think about it now. When I got blown up myself, I don't know, I see it completely different now. Thinking about it, that moment that I got blown up, when it was happening, and everything was moving so slow, and my mind was just racing at the speed of light. I can really go back and visualize it. I've never been able to visualize it so hard before. I can really feel what it was like, and there was this I just feel like I should tell you something. It's hard to put it in words. That aspect of me that's just really rageful, and also, besides that image I told y'all about, the fighting with them, I had this image of it in a jail cell. Yeah, I had that part of me is locked up in jail, and it's just, and I thought of that, and I felt so. I felt like I put that person there. I went to it and just opened the door and like hugged that person, and then the eyes just faded away, and it no longer had kind of an evil look to itself, and like we like I visualized both of us just taking apart the jail cell and just, like really becoming friends. And then I visualized that image I told you about of me, like it coming out of my hips and it stabbing me in the side and everything. And I just had a strong visualization of me like reaching up where the knife was on my side and taking it out, and like took my hands off its neck, didn't choke it anymore, and just like really embraced it. And like, I don't know, I feel like, I don't know, part of me realized that I think that I was taking that person and keeping them locked up because I was so afraid of them. And that by putting them in that cell, keeping them locked up, that I was just making it worse for him. And that was really more beneficial if we kind of worked together. And I'd be, I don't know, it's just like it was really amazing. I never realized how much I thought I was being a peaceful person, but I didn't realize how much I was punishing that aspect of me. I think maybe in Iraq I saw what it was capable of, and I think I was too afraid to, and a part of me just feels like so bad that I did that to him. I mean, I know it's me, but I just describe it wisely.
Yeah.
I don't know, I just got this amazing sense of just, I guess, wisdom. I really don't know.
Sounds a lot like wisdom to me.
It was really amazing. And even when I try and think of that really rageful aspect of me, like I can't even, I know it's there, but it just doesn't make, I really feel like so much more at peace with like everything. Right? Even if I try and think about Iraq and everything, like I somehow feel like really peaceful about the fact that that's my journey. And that, thanks for sharing that. Part of me thinking, I know this is part of the, part of the drug, but when I try and think, am I going to be able to hold on to this understanding, this somewhat of wisdom, this knowledge that I have now? Just ask myself that question. I feel like it's so profound that I don't think I could really get it. And just thinking about it now, whenever I blow up on people or blow up on my wife and get all angry and yelling at her, I feel like it's because I kept that person locked up. And of course, it's going to be hateful and resentful for being locked up. And so when it comes to the surface like that, it's going to be mean and make people cry. I really feel like letting it breathe and letting it be is just going to be so much better for me. Thanks. I don't know, part of me that's saying like it's all your fault that you created all those feelings, the anger and all that other stuff. But then I don't know what part of me is saying that, because every time it says that, that sage part of me just says it's part of being human. It's, I glad I found it. I'm glad too. I just don't let myself feel sometimes so hard.
You still got energy in your body. It's like, yeah.
Pretty groovy. You look pretty groovy. Is there anything in particular coming up? Happy to be alive and thankful for the experience.
Sure. If folks have any thoughts or impressions or questions.
I have a question about touch and like what's appropriate during sessions. And I mean, I'm wondering like what kind of that looks like. I'm sure it's different for each patient, but like, is there kind of a general part of the protocol or something that, or, just wondering about that.
Sure. Yeah, we do feel that, touch can be really healing and helpful for people. And so in the prep sessions, we go over, exactly, what this could look like. It's completely left up to the participant, and we sort of almost, role play what that might be like. So, we might say, you know, if you're feeling like you need some support or some grounding, you can reach out your hand to us and we'll hold your hand. Or we might, place a hand. I mean, it's always going to be, just sort of from kind of the shoulder down, or we might, hold their feet or something that sort of helps them just feel that sense of support. But we always go over it in the prep sessions before we get to the MDMA session. So there's, no surprises there. And, we definitely have a lot of clarity around that. But it is different than, traditional therapy where, the therapist doesn't touch the person. And I'm really glad that that is incorporated in this, because I think it's so, supportive for people to just have that human contact and to know that we're there and we care about them, and we're supporting them. Yeah, thanks for that question.
I have a question about people setting intentions before they start. Just like you had said that another subject was able to better recall her memory of her traumatic event, and that in a sideways way allowed her to explain her anxiety around her dogs. I'm wondering if there are people who think they know what they're going in for, set these intentions, and then of course other things might come up while they are in that therapeutic session. And are people pretty willing to then to verbalize that and share that? Does MDMA kind of suppress those feelings of shame that might have kept those memories suppressed?
Yeah, definitely. That example that I gave about the dogs. So that there's another example, with that particular participant that speaks to what you're saying. She her trauma, her index trauma that she came to the study with, she had witnessed a murder, but actually she had many other traumas too. She'd been raped, she'd gone through Katrina, um, but as we were sort of doing the evaluation, the murder was her index trauma, sort of that's what we call kind of the main thing that's causing her symptoms. But as it turned out, she had never really processed the rape before and spent quite a bit of time on that. And that seemed to be where so much of her healing came from, just being able to talk about that and process that. And it wasn't even kind of the main reason that she was there. But and then also we had another participant that was a veteran, but he had grown up in a small town in the South, as a gay man, and that wasn't even really brought up in the kind of the beginning. But during his MDMA session, he spent a lot of time processing what that was like for him, and how that had kind of affected the way he felt about himself. And so I think that really speaks to the inner directed therapy. Like, there's this inner wisdom that knows what needs to kind of come up, and whatever comes up, that's what we work with.
I have a question. Is there any type of trauma that you would not sort of touch or go into this therapy with?
Well, I mean, and just off the top of my head, there's, we're trying to operationalize something that's pretty difficult, and a primary outcome measure being the CAPS. Wouldn't it be nice if it was just a discrete trauma event that could be processed and, operationalized by CAPS scores? But yeah, life is inherently messy and complicated, but I think we're learning, like, for this particular protocol, if people, and so many human beings do, kind of have ubiquitous developmental traumatic events in the early caregiver environment, and where they live, that it starts to blur. And for purposes of this research, I think we're generally trying to screen more for discrete trauma, but of course that rarely happens. But if we're successful in getting this medication off Schedule 1, then I think there's no trauma we wouldn't want to work with. It's just there are some exclusionary criteria, like a primary psychotic disorder being one, or if there's current depression with psychotic features, or if someone carries a diagnosis of bipolar type 1, then it might not be an appropriate therapeutic for them. But time will tell about that. Time will tell, because it may turn out differently. But just for the purposes of trying to bring a medicine to market and get it off Schedule 1, those are some of the exclusionary criteria.
Thank you.
I couldn't separate these graphs, but I just kind of wanted to show you these are sort of the latest results of the study. And so the blue line is placebo and the red line is MDMA-assisted psychotherapy. The top graph, they're looking at the CAPS scores. So as you can see, the red line, you can kind of see on the left, this is the CAPS score. And so at the end, after 3 sessions, people's CAPS score, went way down below the placebo group. And then the second one is the Sheehan Disability Scale. And that scale really measures, just a person's ability to work and function in their everyday life. And then the third one is looking at the Beck Depression Inventory. And so as you can see, the MDMA-assisted psychotherapy helps, all of 3 of those scales are much improved. We do a lot of kind of pre and post psychometric measures. But these are just 3 of the ones that were published in the latest Nature Medicine article. And then this just kind of, this window of tolerance is, when you're working with someone with PTSD, as Ray was mentioning earlier, it can be really challenging for people to talk about their trauma. You know, they kind of go into this fight or flight response, and their body just gets, they just get so worked up, and they can't really go into it. And, you know, on the other end of that scale is, you know, numbing of emotions, kind of a hypoarousal, being, you know, even kind of dissociating. And so the window of tolerance is this area kind of in between those two things. And I think that one of the other reasons that MDMA is really effective is it increases dopamine, which I think the amphetamine component of it kind of gives people the motivation to want to talk, so that they're not just kind of lying there listening to music the whole time, you know, just kind of chilling out. They have kind of this motivation to want to work on, you know, the reason that they're there. And so they can sort of, you know, get into this window of tolerance where they're able, you know, they're able to really do the work. And this is just a quote from one of the participants that I wanted to read. "I don't think I would have survived another year. It's like night and day for me compared to other methods of therapy. Without MDMA, I didn't even know where I needed to go. Maybe one of the things the drug does is let your mind relax and get out of the way, because the mind is so protective about the injury." I think that's a really kind of great description of what it does. These are just some of the side effects that people have from the medicine.
And I guess they're self-resolving. They're, you know, adverse events from the sessions, but they weren't, I don't think they were serious, and they self-resolved.
Yeah. And then just in case any of you guys are interested, you know, once this is moved from a Schedule 1, kind of the limiting step there is going to be that there's not that many therapists trained in this modality. And so MAPS has a therapy training program that it's a really great program, and they're trying to, you know, train as many therapists as possible to sort of get, you know, ready for this to become available. But this just kind of shows, you know, what the training involves, in case anyone's interested.
Shari, can you speak to what would be maybe some like prerequisites or qualifications to the training? Like, do you have to be in the field of, you know, as a therapist or a clinician or whatnot? What does that entail?
You can be a nurse. Nurses can apply, you know, it's if you have some experience working with trauma, but you know, yeah, it's open to kind of, you know, therapists, nurses, psychiatrists, and the training just kind of, you know, goes into specifically this type of therapy. And you know, it involves watching a lot of videos like the one that we watched of Nick, and you know, just kind of really learning from seeing the actual process happening. And then you know, learning about internal family systems is a modality that we use. And you know, there's other sort of things like holotropic breath work that can really help with the integration of the experience. And then we video all of the sessions and have a supervisor that watches them and then gives us feedback and kind of, you know, tells us, you know, how we could have done this differently. And so it's sort of this you know, constant process of just learning and growing.
And is this information on the MAPS website, or where would people get information about this?
Yeah, they can go to maps.org, and there's a place there that you can apply for getting into the training. I think they're starting the next one in August.